today's office hours is 10 questions to ask your healthcare provider if you've been prescribed an antibiotic. And why is this so important? It's important because the biggest way to prevent dysbiosis, the most effective way, which you know is imbalance in the microbiome, is to not do the things that cause it in the first place. So I get so many questions in my practice through social media saying, I took an antibiotic for, I just got something yesterday from somebody who unfortunately was given prophylactic antibiotics during pregnancy, during most of her pregnancy, and then had C. diff and is sort of haunted by that. And what I realize is so often with antibiotics, people don't realize that there are actually options. So I'm trying to keep the barn doors closed and not, after the horse has already gone out, figure out what to do. Hello, Instagram. I'm also on Zoom, so I apologize that I'm not looking directly at you. So again, the most important thing is to make sure that that antibiotic you're taking, that it's absolutely necessary, and not to be trying to fix the damage, to remediate the damage to the microbiome after you've already taken the antibiotic, which is much more challenging. Okay, so let's get started with question number one. Question number one is this antibiotic absolutely necessary? And here's the deal. I've talked about the study before from the journal Pediatrics that showed that pediatricians prescribe antibiotics 63% of the time when they think the parent expects one, and 7% when they don't. So you need to be the kind of patient, whether it's for your child or yourself, who has one eyebrow raised, who's like, yeah, is this antibiotic absolutely necessary? And let your healthcare provider know, whoever's doing the prescribing, that you would rather not take an antibiotic unless it's absolutely necessary. Okay, so that's the most important question. And obviously you say it in a nice and gracious way, but let them know you are the kind of person who prefers not to take an antibiotic if you can get away with it. So question number one, is this antibiotic absolutely necessary? Okay, question number two, and I wrote them down in the order because I want to make sure I get the order right for you. And these are also in my second book, The Microbiome Solution. There's a whole section called A Rewilding Approach to Illness that talks about how to treat sinus infections, urinary tract infections, acne, all kinds of things without antibiotics, and the questions to ask, and also a birth plan for those of you who are thinking of conceiving or might be pregnant, for how to have a birth that is has more microbes and fewer antibiotics so that your baby can inherit a healthy microbiome. But back to question number two. Second most important question to ask is, are you prescribing this antibiotic for an infection that I already have, or to prevent an infection that you think I might be at risk for? Okay, so that's really distinguishing between treatment for an active infection versus prophylactic treatment to prevent a possible infection. And there's a big difference between those two things, because we know that when we think about antibiotic prophylaxis, for example, in the GI world, for decades, if you had arrhythmia such as atrial fibrillation, or if you had mitral valve prolapse, which is a very common abnormality of one of the valves in the heart that a huge percentage of the population have, we were giving you prophylactic antibiotics. Well, the study was done and it turned out that the risk of the antibiotics, getting C. diff, having antibiotic-associated diarrhea, et cetera, was far greater than the outcome we were trying to prevent, which is endocarditis, an infection on the heart valve. And it turned out that people with mitral valve prolapse having a colonoscopy really weren't at risk for endocarditis. But at the time, we were still giving it because we were in this sort of, well, it can't hurt, right? We really weren't recognizing the damage that these antibiotics can do, the hit to the microbiome that's associated with obesity, cognitive decline, autoimmune disorders, allergies, etc. So now we know, we looked at those studies, and I'm very proud to say that I was part of the Standards of Practice Committee for one of our large GI societies that said, yeah, no more. And we narrowed down those guidelines for preventive treatment to almost nothing. There are very few. There are only one or two indications now where you would be getting prophylactic antibiotics if you are going for a colonoscopy. And the same is true for the dentist. But again, a lot of the dentists maybe are not as clued into the microbiome. And so if you're getting antibiotics before a teeth cleaning or something, and you've been getting it for decades, and they're telling you, well, you have mitral valve prolapse, I want you to ask the dentist, again, graciously, and say, are those still the current guidelines? Could you check? because I know in a lot of other areas, I don't need these antibiotics anymore. So again, the harm that we were causing by a lot of these antibiotics was much greater than the condition we were trying to prevent. Okay, so that's question number 2. Is this being used to treat an infection I have or to prevent one I may have? Same thing, if you're getting dental work and they're telling you they want to give you antibiotics or before a cystoscopy, all of these different conditions. A cystoscopy is a procedure where they look at your bladder. So all these procedures that are invasive, that are felt to, disrupt what's going on microbially, there are very few of them that actually warrant an infection based on the study. So I want you to ask them. When I was having some dental work, you all know about my dental disaster earlier this year, snowboarding accident, cracked tooth, root fracture, eventual extraction. I won't bother to show you the hole in my mouth right now. But one of the things I did for a lot of that work I was having is I said to them, how essential is it that I take an antibiotic? For the extraction, I had to take it because the tooth had shattered and it had been broken and infected for several days. But for the implant, the fantastic oral surgeon I saw, Dr. Ziad Ali, he said, you know what? My preference is that you take it, but you don't have to take it. And here's what we're going to do. I'm going to give you this oral rinse to use a couple times a day for the first 3 or 4 days. Use that, and you don't have to take an antibiotic. And of course, a rinse itself had some, antimicrobial activity, but much, much less than an antibiotic, minimal. And I only had to use it for a few days. So it's like I always tell my daughter, you never know. If you ask, the question might be, yes, you don't have to take it. But if you don't ask, you're never going to know, right? So make sure and ask that question too. Okay, question number 3. This is an important one. Hi again, Instagram. I'm also on Zoom, but starting next week, we're primarily going to be on Instagram and we'll be looking at you and also have the Zoom open. Okay, question number 3. I forgot, I have to look again. Okay, yes, culture results. Are there results from an actual culture? That could be a blood culture, it could be an oral swab, it could be a urine culture, it could be a stool culture, etc. So whatever body fluid or blood that you're sampling, are there culture results indicating an active infection? And is that why you're treating me? Or you're treating me because you think I'm going to have an infection, or you're waiting on a culture result? Here's the deal. Waiting on the culture result will tell you not only what the organism is, but something else really, really critical called the ID&S, the infectious disease and susceptibility. Okay, so the actual identification of the organism. Like if you have a urinary tract infection, is it E. coli? Is it Enterobacter? What is it? So that's important. And is it even sensitive to the antibiotic you're taking? Because of the massive overuse of antibiotics in society, what we've seen is that, if you hear that, that's my husband mixing his psyllium husk in the background. Okay, so back to the culture. So what we see is that because antibiotics are so overused, it's not uncommon for that bacteria to be resistant to the antibiotic. So what so often happens is they treat you before the culture result comes back. You've already taken 5 days of an antibiotic, and then they call you, oh, guess what? The infectious disease identification and susceptibility came back. It's not actually sensitive to that. You have to take another antibiotic. And here's the problem. The first antibiotic you took may not have been effective against the pathogen, but it's killing off droves of your healthy bacteria. And now you have to take an additional bacteria for longer. So you have extended the amount of time you have to take an antibiotic. It is generally preferable to wait a couple of days for the culture results, assuming you don't have a life-threatening infection. It's not flesh-eating bacteria or a serious bacterial pneumonia or something. If it is a bladder infection, yes, you'll be uncomfortable a little bit longer, but waiting those, typically that comes back in about 2 to 3 days. Waiting that time will make sure that you can get a more specific antibiotic that is directed against the actual pathogen and not needlessly kill off healthy bacteria while you're not actually treating your infection. Okay, so that's question number 3, the culture results. Question number 4, what other options are there besides this antibiotic? You would be shocked at how often the answer is, well, you don't actually have to take the antibiotic, or you know what, there's a lot of inflammation associated with this process, so I'm going to give you an anti-inflammatory drug. Now, of course, those themselves are fraught with problems if you are taking an NSAID, right? But NSAIDs, while they're damaging to the gut lining, they are not as hard on your microbiome. Your microbiome isn't going to take the same kind of hit. So if you can take a non-steroidal anti-inflammatory drug or some other kind of anti-inflammatory, you can take it at a lower dose. Maybe you can combine it with some acetaminophen so it's less damaging to the lining. In certain cases, that's far preferable to an antibiotic. What would those certain cases be? Well, if you're somebody who has taken a lot of antibiotics to begin with, so you already have a lot of microbial disruption, it would be preferable in that setting. So remember that a lot of times what they're treating as an infection is either often an inflammatory process or there's also some inflammation going on, and that's the main thing they're trying to treat. Case in point, a lot of my patients with inflammatory bowel disease, like Crohn's disease, when they have a flare, gastroenterologists, not me, will treat them with antibiotics, but that's an inflammatory process. It's not an infectious process. And we know that specific gut anti-inflammatory drugs, like 5-aminosalicylic acid derivatives, can be very effective against inflammation, not going to take a microbial hit in the same way. So again, ask about other options besides an antibiotic. Okay, that was question number 4. Question number 5. What is the natural course of this illness without an antibiotic? So if we look at something like strep, we don't actually use antibiotics to kill the strep, or primarily because strep is such a terrible, dangerous disease. It can be in rare conditions, but strep throat, the reason we use antibiotics is to prevent 2 extremely rare conditions. One is rheumatic fever, rheumatic heart disease, and the other is post-strep glomerulonephritis, which is a kind of kidney disease. These are both extremely rare. I have seen people who had rheumatic fever, but they're much older, and this was a long time ago. So we don't actually need the antibiotics for the strep itself, because strep throat is a self-limited infectious disease in the majority of cases. The antibiotics shorten the duration of the illness by a few days, but again, we're using it to prevent these rather rare complications. So in a case, and again, this is not medical advice, this is education. The decision about whether to treat your strep throat or your kid's strep throat needs to be based on a dialogue between you and the pediatrician or you and the healthcare practitioner, okay? So don't base it on what I'm saying, but know again that the natural course of strep, it will resolve in the vast majority of people with no complications. You need to check with a doctor to see if you can be one of those people, and understand that it's not like if you don't use an antibiotic, the strep throat will never, ever get better on its own. But again, the context of this is so important. How sick are you or your child? What is your background history? You know, all of these things, right? How severe is a strep throat? How bad are the symptoms? But I just want you to know the options. Okay. Number 6, how long will it take to feel better without this antibiotic if I didn't take it? And this sort of harkens back to what I was just talking about with the strep. It is possible for these things to resolve on their own, to heal on their own. So you want to know what's a natural history of this, because you'd be shocked to find out how much of the time what you're really getting is 2 days. Okay, so the natural course with antibiotics is 9 days. The natural course without antibiotics is 11 days. Most of us would be willing to be sick for an extra 2 days to avoid the deleterious effects of the antibiotic. All right, that was number 6. Number 7, what is the least amount of time I can take this antibiotic for? What's the shortest amount of time? Now, you read a lot in the literature and you see a lot in the news about how dangerous it is to take an antibiotic for less time than is prescribed. And that's true because you don't want to partially treat something and end up with a resistant organism. You want to make sure the infection is completely treated. But that being said, there is still a tremendous amount of variation for how long that complete course is. It could be 5 days, it could be 7 days, it could be 10 days, it could be 2 weeks. Sometimes it's as quickly as 3 days for certain urinary tract infections, depending on the organism. So obviously, the less time you're on the antibiotic, the less damage it's doing to the rest of your gut microbes. So that's an important question. Okay. Number 8, we're moving right along. So as soon as I finish 10, we'll start taking questions. We'll see how I manage with the questions on Instagram and Zoom. Number 8 is, and this is a really important one, is there a more narrow spectrum antibiotic? We are in the era of broad spectrum antibiotics. And the reason is we're often not sure what the organism is. We're not sure what the susceptibility is. So we cover, it's a CYA, but it's cover your ass, not the doctor so much. We cover for a wide variety of possibilities with antibiotics that are active against a wide variety of bacterial species. But here's a problem. They're also active against a wide variety of your healthy bacteria. So the more narrow spectrum the antibiotic, the less killing you're going to get of your healthy bacteria. Penicillin is one of the most narrow spectrum antibiotics. And believe it or not, penicillin is still active against a wide range of infectious organisms. So here's where having that identification and susceptibility information is key, because they can say, yes, we are trying to kill this particular organism. And here's a list of 7 antibiotics that it's sensitive to. This is what the lab reports. When they do the culture, they identify the organism, they run these assays to see, what is the minimal amount of various antibiotics that are effective in eradicating it. So let's say you have a choice of 7 antibiotics. Within that choice, there's going to be a wide range for which are more potent, killing off wide swaths of bacteria versus which are more narrow and directed. And you always want the most narrow spectrum one, once they know what they're treating. So ask about that. Ask about good old penicillin, super cheap, much less deleterious to the rest of your microbiome. Number 9, if I don't take this antibiotic, what are the signs and symptoms to watch for that would indicate that my condition is worsening? Okay, so let's say you have strep throat and you decide, I want to try and tough this out without the antibiotic. You need to know ahead of time, and it may even be a good idea to take the prescription, get it filled, and have the antibiotic sitting right there in case you need to start it at 11 o'clock at night or, on a Sunday afternoon or an inconvenient time to get to the pharmacy. You want to know, what should I be looking for? In the case of strep throat, it is often a peritonsillar abscess. So it's an abscess that can develop where, the tonsils are really inflamed, and that can be a really severe complication. It can even be a medical emergency if the abscesses get so big that they can impinge on your airway, etc. That doesn't happen overnight though. So you want to ask them, what should I be watching for? Should I be watching for, worsening pain in my throat? In the case of that, should I be watching for a fever going above a certain amount? Should I be watching for additional symptoms like nausea or listlessness or lethargy or a loss of appetite or a stiff neck, depending on what the thing is you're treating? If it's a urinary tract infection, should I be watching for more severe pain higher up that could indicate an ascending urinary tract infection leading to the kidneys, something called pyelonephritis, which is generally much more severe than just a urinary tract infection. In my practice, we often treat urinary tract infections with something called D-mannose, a supplement, and it can work really well for E. coli infections, both to treat active infections and to prevent infections, but it's sometimes not effective. So if somebody were on D-mannose and they were getting worse, they were having more burning, more frequent urination, a fever, more flank pain, I would want to know. And there is a certain point where I would be like, oh yeah, you actually need an antibiotic. So you want to know that information ahead of time. You want to arm yourself with that critical information. Okay, number 10. And, this last one is covered in some of the other ones, but, I think it's still a good question to ask. What's the worst thing that can happen if I didn't take this antibiotic? Worst possible outcome? Death? Yeah, take the antibiotic. Serious debilitation, take the antibiotic. But, what else? Because if the worst thing that could happen is, oh yeah, you're going to be sick a couple of days longer. Definitely, I would not, in that situation, I would be like, okay, I'm fine. I'll tough it out a couple of days longer, right? So you want to know what's the worst possible thing that could happen. Like if we take a case of viral meningitis, we know that viral meningitis is not in any way something that can be treated effectively with an antibiotic because it's caused by a virus, and viruses are not susceptible to antibiotics. However, what if the doctor isn't sure that it's viral meningitis? What if they're like, you know what? We think it's viral meningitis. We did a spinal tap, a lumbar puncture. We didn't see any bacteria, but we saw more white blood cells than we expect. Sorry. And we're worried that there could be a bacterial meningitis that we're missing. And what's the downside of not treating for that? Well, the downside of not treating bacterial meningitis with antibiotics is pretty severe. That's some pretty stark potential ramifications. So in that case, that's one of those things where it's kind of prophylactic, right? They're not sure. And so maybe ask them, well, what's the probability that this is actually bacterial meningitis, not viral? If they're like, oh, it's 1%. But if they're like, oh, it's 20%, so again, I think what I'm trying to encourage you to do over and over and over again is to have a dialogue, have a respectful, open, gracious dialogue back and forth. And, I think most doctors have your best interests at heart. Like they want you to have a good outcome. And what they are looking for is some guidance as to what kind of person are you when it comes to antibiotics? Are you willing to assume some risk? What kind of risk? What's your background history? Are you somebody who's had, 2 episodes of C. diff in the past after antibiotics? Or have an autoimmune disease that flares up with antibiotics? Or, the flip side of that, are you somebody who is at high risk for having a complication of this infection? Like, let's say your kidney function is compromised from something else, from high blood pressure. And now that, if this urinary tract infection becomes pyelonephritis and affects your kidneys, that could worsen your kidney function. And that's something you want to avoid at all costs. And so again, this is a conversation you might need to rope your nephrologist in, your kidney doctor in that particular situation. If you're pregnant, you really want to consider, well, what is a potential risk to this fetus if I take these antibiotics? Or if I don't, could the infection spread to the fetus? So, there's rarely a straight line in medicine from here to there. It's often it's a convoluted journey. And these are great questions. I mean, all the really important, helpful stuff I know, I dare say, so much of it I know because people asked questions. And sometimes I had the answer and sometimes I didn't. I had to go find the answer. I had to literally call a friend, pick up the phone, call my nephrologist colleague, who at the time, Joyce Gonen at Georgetown, was this incredible South African physician, one of the most amazing patient advocates. I would call her up. Hey, Joyce, I have this patient. This is what's going on. Call up Dr. Princey Kumar at Georgetown, the head of infectious diseases, another incredible patient advocate. Like, let's put our heads together, right? So all of this is a conversation. And my goal with these office hours is to really arm you with what I consider essential information and helpful information, not inflammation, to help you arrive at the right answer. So, okay, that's enough talking from me. Let us take some questions. I'm going to start with Zoom and then I'll see what's going on Instagram. Okay. And I realize Instagram, I could have set this up better with the camera so I look like I'm looking down versus looking at you. I'll get that squared away. Okay, we have a question from Andrew. I have been on a combination of Cipro and Flagyl for diverticulitis. So again, that's diverticulitis, not diverticulosis. So what Andrew's talking about is active inflammation of those diverticular orifices. And again, there's a fine line with diverticulitis between, is it just diverticulitis and there's inflammation, or is there also infection? So he's been on a combination of Cipro and Flagyl once or twice a year for the past 10 years. So again, you add that up once or twice a year, let's say twice a year, a week at a time, that's 2 weeks times 10 years, that's 20 weeks, that's about 5 months. And, we have data showing that we can start to see cognitive decline after about 2 months of antibiotics. So, this is significant. After recovery, and again, Andrew, I'm not suggesting that you have cognitive decline from it. I'm just saying there's a higher risk. After recovering from each episode and completing the antibiotics, I have more and more frequent bowel movements per day, going from 1 to 6. So yes, what is likely happening there, Andrew, is you have dysbiosis from the antibiotics, like the ciproflagyl, which is a standard, combination for this diverticulitis flare. What we know is that it's also inducing a lot of dysbiosis. It is creating a more imbalanced microbiome. So it, maybe prevents an acute big episode like an abscess or something. In my experience, Andrew, and again, I'm not your treating doctor, what I have found is that putting people who are having an episode of diverticulitis, assuming there's not severe pain, assuming there's not a high fever, assuming there's not severe tenderness, is putting people on bowel arrest, just a clear liquid diet, broth, etc., for a few days so things can quiet down, and then using an anti-inflammatory diet to really help heal the gut. And Andrew, go back to office hours on either the YouTube channel, gutless.com or robinchutkan.com. Look at the archived office hours on diverticulosis, watch that, and then go to our free gut guides, again, on robinchutkan.com and gutless.com, read the section on diverticulosis, and I think you'll find a lot of useful information there. But I think that's what is happening with more bowel frequency as a result of this dysbiosis. Foods or supplements that I can take to help reduce the amount of bowel movements. My gastrodoc says that antibiotics have caused IBS. Your gastrodoc is right in a way, but the more specific thing, everything gets put into this IBS grab bag. It's likely that they've caused dysbiosis, an imbalanced microbiome. So plenty of resources for you, Andrew, with archived office hours on diverticulosis. Check out the one also on rehabbing the microbiome, and then look at the gut guides. Okay, thanks so much for joining us. All right, Lynn wants to know, I've tested positive for SIBO with constipation, have taken Xifaxan, that's an antibiotic for those of you who are not familiar with it, 10 days, and my constipation actually worse. Should I have taken neomycin? That's a different antibiotic. No. Should I take it after Xifaxan? No. So here's a problem, Lynn. A condition that is primarily caused by overuse of antibiotics, which we know is the case for most people with SIBO, is not going to be cured with antibiotics. And so we know that gastroenterologists sort of promote SIBO as it's this problem that's caused by having overgrowth of bacteria in the small intestine. But really what's at the root of SIBO is imbalance. You have wiped out a lot of the essential bacteria, and that's why you have overgrowth in the first place. So if you just keep treating that with antibiotics, you can see that you're going to continue wiping out the population of healthy bacteria and really get into a rut. So again, lots of resources. Check out archived office hours. Check out the gut guide on SIBO for a different approach, a rewilding approach that involves repopulation rather than killing off bacteria. Okay. Jean came in late. Okay, so Jean, this is going to be archived on the Gutless YouTube channel and also on both websites, but you came in late. First two questions. One was, is this antibiotic absolutely necessary? The second one is, are you using this antibiotic to treat an active infection or to prevent a possible infection? So active treatment versus prophylaxis. Okay. Yeah, the erythromycin, Lynn, that's an antibiotic too. No bueno. So I want you to ask about non-antibiotic ways to treat this. And, depending on their orientation, they may not have any, but we have some other resources for you. And I want you to discuss them with your doctor, because again, I want you to have the dialogue with your doctor. I want you to have full transparency. I don't want you to be, doing stuff that I told you behind their back, because they're your doctor. So I am challenging you to get them on board once you explain to them what's going on. Okay. Kate wants to know, if your child has been diagnosed with pneumonia, how do you find out if it's bacterial or viral pneumonia? Kate, that's a great question. Ask them for the culture results. Ask the pediatrician, okay, you're saying this is pneumonia based on what it looks like, maybe on an x-ray. Have you done a culture, a sputum culture? What is that growing? You can also ask them to talk to the radiologist. This is not by any means 100% reliable, but sometimes the pattern of the infiltrate on the x-ray could suggest viral versus bacterial. But the main thing would be, is there a culture result that you're also using to help make that determination? Kate is also asking about group B strep during pregnancy. That is, such a fraught issue. And I'm going to pass on that, Kate, because I'm not an OBGYN, but let's just say we are treating tons of people with antibiotics who don't need them to prevent this complication in the baby from group B strep, which is some eye problems. And it's a conversation you need to have individually with your OBGYN and ask them, well, what's the risk of, the baby having vision problems from this? And is the antibiotic absolutely necessary? So that's a little bit dealer's choice. I don't love it when other doctors tell me how to practice my field, which I see as both a science and an art. And so I don't love the idea of like, you got to tell the doctor to do this. What I do love is when people come to me with thoughtful questions and even saying, you know, this other doctor said this. What do you think about that? So, you know, ask them, is this really necessary? Okay, somebody wants to know what is D-mannose. So yeah, D-mannose is basically, you know, when you drink cranberry juice for UTIs, which is usually not super effective. So D-mannose is the active ingredient in that in a more concentrated form. And all the information about that is in the second book, The Microbiome Solution, the chapter on a rewilding approach to illness that talks about the dose of D-mannose, et cetera. But you can also look it up on the internet. You don't necessarily have to buy my book. Okay. They said to let them know if symptoms are worse. I had no symptoms. Would you treat? Okay. So this person is saying, I've had E. coli twice in the last 6 months in the bladder. First time, 100,000 colony forming units. And I'm glad you mentioned that because greater than 100,000 colony forming units is typically the criterion we use to say there's an actual infection. Last time 60,000. So 60,000 falls below the threshold. And they said to let them know if symptoms worse. I had no symptoms. So I personally, and again, not your doctor, this is not medical advice, but if you have no symptoms and you have 60,000, to me, that is not a clear indication for treatment, okay? But you need to discuss it with them. And that's a setting where the D-mannose may really help you. Okay, UTI, okay. All right, let's, are there any antibiotics that don't disrupt your gut microbiota? They are not, because by definition of an antibiotic is antibiota. It's something that is acting against the microbes. Where did I say my SIBO resources are for Lynn? Okay, Lynn, gutbliss.com or robinchutkan.com, first and last name, tricky spelling, just look it up. As well, on both those websites, there is a section called gut guides. They're free gut guides, and they're listed. There are like 35 of them. So look up the SIBO one. And then I also did an office hours on SIBO. And those archived office hours are on both websites, and they're also on the Gut Bliss YouTube channel. Okay. Somebody says, I use catheters, and I assume it's a catheter for bladder catheterization, and take nitrofurantoin. That's an antibiotic prophylactically for UTIs. Does this disrupt the gut microbiome? Yes, it absolutely does. So one of the pretty chronic causes of dysbiosis are people who self-catheterize, and you may self-catheterize for, you may have a bladder condition why you have to do that. It could be a spinal cord injury, whatever the reason. Using the antibiotics prophylactically can. And so again, because the catheterization of the bladder is considered an invasive procedure, for decades, we always recommended antibiotics, but that's now changing. So you could definitely ask your urologist or whoever is the person who is managing this self-catheterization protocol, you could definitely ask them, hey, do I still really need to take that nitrofurantoin? Could I just wait and see? And, you know, if I don't get a bladder infection, great. And if I do get a bladder infection, then I'll take it. And, you know, what I find is sometimes the more specialization the doctor has in the field, the less likely they are to tell you you need the antibiotic. Because, so I'll give you an example. If your family practice doc or your internist is managing this, they may not know. And they may just be like, yeah, I'm worried about you getting urinary tract infection, take it. But if you're seeing a urologist, they may be very aware of the recent guidelines and say, you know what, our recent guidelines don't call for that. But a family practice doc is probably less aware of what the urology guidelines are. And again, this is a generalization. They have family practice docs who are incredible and know everything, and urologists who are not up on the literature. But again, really, really important to not just accept that, okay, this is the way it is, but to say, do I still need to do this? In fact, you can go yourself to the guidelines, to the medical guidelines. For example, in my GI world, the American Gastroenterology Association, the American Society for Gastrointestinal Endoscopy, so the AGA, the ASGE, and the American College of Gastroenterology, all three big advocacy organizations, for gastroenterologists also have a public facing piece, and they have those guidelines up there on the website. So you could actually look up guidelines for antibiotic prophylaxis for self-catheterization. Okay, again, I want to make sure you got that. Guidelines for antibiotic prophylaxis for self-catheterization. Go read the literature, see what, usually NCI, NCBI, NIH, they're usually, great resources in PubMed online. You may find an article, a study that was done saying, guess what? The risk of taking nitrofurantoin every time you do this is much greater than the risk of a bladder infection. And it may be an article that your physician is unaware of. I mean, as much as we try to keep up with stuff, we're not, it's not always possible to keep up with every article. So I want you to engage them in that conversation. And how amazing would it be if the verdict is, yeah, actually, you don't have to take this antibiotic. Let's just watch you and see if you develop a urinary tract infection, and you may be able to use a D-mannose to help you with that. So that would be a dream for me to hear back from you and to find out that I asked that question. They said I don't need to take it. And because you may be fine now, but sort of this endless dosing of nitrofurantoin, your microbiome is likely to take a hit. So circle back to us on that. Okay. My brother had frequent catheters following aquablation. I'm not sure, maybe that's a typo, and developed what doctor treated for fungus, horrible burning, itching, forget the name of the cream he used, ordered by urgent care, urologist disagreed, culture came back negative, symptoms have decreased. There you go. Okay, let's see what is happening on Instagram. Okay. Okay, lots of questions. Okay, let me bring this a little closer. And okay, going all the way to beginning. Oh, somebody just listened to my interview with Dr. Yami podcast. That was a lot of fun. Dr. Yami, she's such a wealth of information. I was so happy to be on with her. And you're so welcome. Let's see what else we have. Scroll down to the questions. Okay, my son's pediatrician says that strep won't go away on its own. Is that true? That is not true. And there are lots of articles documenting that strep can resolve on its own. It doesn't always resolve on its own, just like it doesn't always respond well to treatment, but it can. So again, go look up those articles and show them. Okay. Any thoughts on prophylactic use of antibiotic before dental appointment, years after a joint knee replacement? Thank you. Yes. So I'm less familiar with the dental guidelines, but I'm very familiar with the GI guidelines because I helped to write them. So with the GI guidelines, a colonoscopy is a lot more invasive than dental work, typically, unless you're having an extraction. Colonoscopy really getting up there. And we have done away with prophylactic antibiotics for knee replacements, particularly if it's not a fresh knee replacement in the last 6 months. Okay, but what I have to tell you is that I'm not up on the dental, what those guidelines are, but I would ask them. And I suspect that you don't need the antibiotic. Okay. I have a 1.5-year-old son, how fun, diagnosed with IBD. He is on Bactrim and oral Vanco, and it keeps away his symptoms and betters his labs. Remicade is our next step. What do you think? What would you do next? I'm not sure that's a 1.5-year-old son or a 15-year-old son, but either way, this is a problem. A study that was published in the journal Gut, one of our journals, some years ago, showed that these antibiotics, particularly, he's on Vanco and Bactrim. This study, they found Cipro and Flagyl were the worst, but Bactrim and Vanco is a pretty, it's a pretty rough combination on the microbiome. Yes, it does help symptoms because it kind of sterilizes a gut. But the problem is when he's off those antibiotics and the bacteria start to come back, they're going to grow back very imbalanced. So this is a temporary Band-Aid that is actually worsening his prognosis in the long run. Remicade is the next option. That's a biologic. That's a drug that can be very effective, but of course has serious side effects, infection, cancer, etc. And your son is young. I would ask them about 5 ASAs, 5 aminosalicylic acid drugs. And again, this is educational, I'm not giving you medical advice. I am relaunching, doing a second version of my course that I'm so proud of, Drug-Free IBD, Remission Without Immunosuppression. We ran it earlier this year, a live version, and it was just so amazing to connect with people. I was going to relaunch it with just the videos and the workbooks, and I decided, no, the live component, it's a 4-week course, and every week I send you the workbook ahead of time, I send you an audio lesson, and then we have a live Zoom where we go over all the nitty gritty, all the questions like this one. So I would highly recommend, the registration right now still says join waitlist, but just because we're changing the page, and by the end of the week, registration should be live, or you could go ahead and join the wait list so that you'll get an email with a link directly to sign up once that's live later this week. And really the reason that I created this course was just because of this kind of question of dealing with so many parents and patients who just weren't getting the full picture from their gastroenterologist about what's possible. And my goal was not to provide care, but to provide advocacy and to provide you with the information so that you can go and have a more constructive, productive conversation with your gastroenterologist about what else is possible. Okay, what else do we have? My son's pediatrician, we did that one. Oh my goodness, somebody says, I started following you since high school. You were my inspiration. Now I'm a doctor. No way. Dr. Welly from Zimbabwe. Dr. Welly, please message me. I've got to hear more about this. This is like, I'm going to cry. This is so amazing. Oh my goodness, please connect with me. You're really making me cry now. Okay. All right. Why don't gastro docs tell you how hard it is to get off a PPI? Trying to get my son off, and it's so hard. Love you, sister from another mister. You are so right. And the reason it's so hard is because of this thing called the acid surge, which I know you know about, but for those who may not, what happens is that these drugs really, and again, this is a little off topic for antibiotics, but it's such a great question. Proton pump inhibitors really completely block that proton potassium ATPase, that hydrogen pump that creates acid. They block it. So you have no acid and you can, do all the things that you probably shouldn't do and not have reflux, but it also can treat some problems that are worsened by acid. So there are legitimate reasons why you would be on a PPI. The problem is when you stop the PPI, that pump is now super active. And now you have even higher levels of acid. You have supratherapeutic levels of acid, higher levels than you normally would. But here's the good news. Eventually, your body's homeostasis will kick in and those levels will come back down. But it can take several weeks for that to happen. It can take really quite a long time. So again, on the website, resources, gut guides under acid reflux, I believe it is, or maybe heartburn or GERD, but I do provide that PPI taper there. And what I recommend is you take the PPI, take one every other day for a week, one every third day for a week, one every fourth day for a week, one every fifth day for a week, and then stop. So you taper slowly. And during that time, you use a shorter acting agent that's not going to shut off the pump like an antacid or Pepcid. And you're also really strict about the diet. So I know that your son is not drinking caffeine, but be careful with dairy, late night eating, overfilling the stomach, all of that stuff. Thanks so much for asking. Okay, let's see what else we have. This is so fun. I used to be so scared of Instagram lives. I'm like, oh, I don't know how to do it. And look at me, now I'm doing a Zoom and an Instagram. Woohoo! All right, so we're gonna do a few more questions and then I don't want to keep you guys over. So, okay, so somebody wants to know, did I say that in the last 6 months, guideline is now that antibiotics are not needed for knee replacement done years ago? No, I didn't say that. What I said is that let me turn to Zoom. In the GI guidelines, we don't recommend the prophylactic antibiotics for a replacement that is older than 6 months, okay? So not that in the last 6 months, the guideline changed, but I want to just emphasize over and over and over again that as much as I would love to be your doctor, I am not your doctor. And the advice I provide is strictly for educational purposes. And I don't say this just for the legal disclaimer, right? The legal disclaimer is important. I say that because legitimately, every person, every body is different. And what applies to one person may not apply to somebody else. So you have to make sure you're getting that personalized care and decision-making based on your particular circumstance. So for example, if you already had an infection in your prosthetic joint, in your knee replacement, that completely changes it. On the other hand, if you had Clostridium difficile from antibiotics 2 years ago, that also means that the threshold for antibiotics is much higher. So there's not a one size fits all with this stuff. The guidelines are a basic set of recommendations, and they are meant to be modified based on the personal circumstances. But that 6-month thing was about the knee prophylaxis being fresh. And again, I want to point out that a lot of these guidelines are also based on what the physician's experience is. So if this doctor didn't use antibiotics and then somebody had a serious infection as a result of the procedure, they're probably going to be much more likely to recommend an antibiotic down the road. If, on the other hand, somebody prescribed an antibiotic in a case where there was gray zone, and then the person developed a complication of the antibiotic, which is actually much more likely, like Clostridium difficile or something, they are going to probably think twice before they recommend an antibiotic again. So again, the moral of the story is you are a unique human being. You have unique microbes, unique metabolism, hormones, medical history, everything else. And your medical care should be as unique as you are and personalized. So all of this information is just to help you have a dialogue with your doctor. And this is what I always tell people too. Don't fire your doctor unless they're just a complete asshole. If they're an asshole, fire them, find somebody else. But if they just don't seem up on things, if they seem a bit closed to doing something differently, educate them, help them, open their eyes. That's what people did for me. That's how I got to, be a little more holistic in my outlook, because patients told me what they were doing. I was able to see the results and to know that this was not, hocus pocus. And then I was able to incorporate a lot of these things into the care I was providing and, create a much more integrative approach. So I want you to have those dialogues. I know a lot of these doctors you're talking about, these gastroenterologists who hand out PPIs like water, et cetera. And I'll tell you, most of them are very well-meaning, but they're maybe not as well informed as they could be. They're a little bit scared about what could happen if they didn't use this stuff. So that's where you come in. You come in to educate them a little bit. All right, well, it's been fabulous spending my Tuesday lunchtime with you. This Instagram Live thing is kind of cool, but it's kind of nice having the Zoom. So maybe we'll continue to do both, okay? So don't forget, tune in for next week's office hours on 10 things to do after you've been prescribed an antibiotic. So the horse is already out of the barn. And now you want to know, how can you rehab your microbiome? How can you try and mitigate the effects of the antibiotic? And spoiler alert, it involves way more than just taking a probiotic, okay? All right, until next time. Oh, and one other thing. My new book, The Antiviral Gut, comes out November 1st, but we're really trying to do as many pre-order sales as we can. So if you enjoy these office hours, spending time with me, which I love to provide, but I do provide at no cost, do me a huge favor and just pre-order my book on Amazon, Barnes & Noble, Indie Books. You can get it through the website. If you order now, there's actually a really nice free pre-order incentive, which is a downloadable antiviral gut meal plan, recipes, gut guide. It's really great. I put it together myself. And so do me this solid, as I say, do me this favor, and do go ahead and pre-order the book. I would so appreciate it. And it's a fantastic book. All right. Thanks so much. Let me hang up from this. Let me end the Zoom.